major organs, and of course, those telltale signs of disease processes. So, like I've said a million times before as well, like TNC, for example, test questions, as you guys have seen now, they're structured a lot differently. It's kind of painting a picture and it wants you to figure out what's going on. Because, like I said, your patients aren't going to come in and say, this is what's wrong. A chest x ray is not going to spit out a printout and say, well, this is what's wrong. So, it's going to be up to you, other medical staff, primarily a radiologist, but to figure out what that image is saying. Okay. So again, there are lots of telltale signs and different terminology used to describe what we see on a chest x-ray. And they are specific in a lot of cases to certain disease processes. Okay. So that's really what I want you guys to get out of this unit. Okay. I don't expect you guys to be radiologists when we're all said and done. Every chest x-ray that's done has to be viewed by a radiologist, even though, when you're in ICU and things like that, the pulmonologist might look at it, the hospitalist might look at it, but really it's up to a radiologist to look at it and determine what they're seeing. And if any of you have ever read a radiologist report, you also notice that they're very vague a lot of the times. So it'll say things like, it could possibly be indicative of pulmonary edema. It's a black and white image, it's a 2D image. So these are not definitive, okay? We need to know the reasons why a chest x-ray might be indicated. And we also need to know, again, those glaring signs of what the chest x-ray is saying. And also, again, when it's appropriate, that sort of thing. Okay. And also put what you see together with the patient's signs and symptoms. So a chest x-ray alone is not going to give you a diagnosis. You also need to look at your patient. You need to use those astute bedside techniques to determine when a chest x-ray is necessary and put that together with what you're seeing from your patient to determine what disease process, what condition you have going on there. Okay. So again, a lot of this is visual. So I'm going to send you guys a video. I've already sent you the video and also some web resources so that you can see these visuals to put them together with the stuff that you're reading. Okay. So we probably won't go over the PowerPoints unless you guys have questions about them. I do want you to read the PowerPoints, take notes from them, highlight things from them, and also read the chapters that they're associated with. Okay, so again, you reading the information is one thing, but really I want you to see the images and be able to associate what you're reading with what the image is. Okay, so again, we're going to start with your homework handout, so have that in front of you. So the first thing that you saw on that handout was 3 different images, and you were asked to identify what each of the image was showing. Okay, so the first image, of course, is a left lobe atelectasis, and we know that it's a left lobe. How can we identify? Well, do you agree that it looks like a left lobe atelectasis? Is that what you chose, or did y'all select something different?
I had looked in the book, and so like even though I knew that would be like that it looked like an atelectasis. When we looked exactly at an image, it also showed that they were like the patient was already assessed with that and that they had put a chest tube in. So I had put it in as the ET tube like placement.
So where are you getting that from? What on this image tells you that there's
I believe I had looked into CARC and the same exact image, and they were showing it had the arrow like that, showing that it was ET tube placement.
Okay, well, keep in mind that your ET tube should be where? Where does the ET tube go?
Oh yeah, it goes right here.
It goes in your what?
Okay, the trachea.
In the trachea, which should be where?
Like 3 inches above the cornea.
Well, your trachea is midline. Your trachea splits into your carina, but your trachea should be midline. What this arrow is showing you is that the trachea is no longer midline.
Oh, okay, I see what you're saying.
Yeah. So I don't want you to compare to another picture. I want you to look at it and determine what you see, right? Because when you see chest x-ray images, it's not like, oh, let me go in my book and find what this looks like. In some cases, that will help you starting out, but you're to evaluate the image that you are given, okay? So what this arrow really is showing you that there's a tracheal shift, right? Is the tracheal shift towards or away from the problem?
Well, that pulls it towards.
We know that white indicates what on a chest x-ray?
If it was towards the right, it would have been
No, the color white. White.
oh, the color white. Radiolucent
What does that mean?
consolidation.
Okay, so white is anything other than air on a chest x-ray,
Okay.
right? So there are different shades of white, so to speak. You'll see anywhere from stark white to shades of gray. But anything that's not black on a chest x-ray is something other than air, because air is black on a chest x-ray. Okay, so the fact that this lung field is white tells us that it is not filled with air as it should be, right? So that could be a pneumonia, consolidation, fluid, phlegm, something like that, or a collapse, of course. And the fact that we have a tracheal shift towards the problem is what, along with it being white, is what tells us, okay, well, no, it's probably not pulmonary edema because you don't have a tracheal shift with pulmonary edema, right? It's not a pneumo because there's white over here and you have the tracheal shift towards the problem. So putting all that together is what should allow us to assume that this is a left lobe atelectasis. Does that make sense?
Yes.
Okay, so B, what do you think? What'd you pick? So what'd you write in there?
I said absorption atelectasis because of the whiteout.
Okay, and we don't know the patient's history. So again, we have to make sure that we either are given a patient history or assess the patient in front of us. So we don't know, how do you get absorption atelectasis? Where does that come from? How does one develop that?
With
Isn't that when you're
O2 toxicity?
Go ahead, Amanda.
O2 toxicity?
Yeah, so what are the requirements, though, of giving a patient O2 that leads to absorption atelectasis? There are two contributing factors.
Is it time,
So, and what do you mean by time, AJ?
duration? Like
So how long puts you at increased risk?
more than
Over 24 hours.
Right, 24 hours or more is what puts a patient at increased risk of developing absorption atelectasis. What's the other factor?
flow rate?
Not the flow rate, close though.
Amount, the amount of O2 or the
Right,
FiO2.
and what's that called? The FiO2, exactly. So, and what FiO2 puts a patient at increased risk of developing absorption atelectasis?
100.
50 or greater. 50 or higher. So high levels of oxygen. What's high? 50 or greater. Long time. What's a long time? 24 hours or more. So because we don't know whether or not this patient is on oxygen, if they just showed up like this or what, we would just consider it a whiteout. It could be atelectasis, it could be consolidation, it could be pneumonia. So again, we have to look at the patient, right? If they have purulent sputum, maybe complaining of chest pain, diminished breath sounds, they had a fever, might be pneumonia, right? If they have recently had a tummy tuck, right? And they've been laying in bed, no fever, not taking deep breaths though, then it might be atelectasis. Then you have that patient who maybe they had a pneumo and they put them on 100% non-rebreather because of that, and now their chest x-ray looks like this. Then we could assume it's absorption atelectasis. So again, we gotta put, the chest x-ray alone won't tell us what's going on. We have to put it together with the patient's history, but it's not black. So that tells us that those lungs are not air-filled. So we just call that a whiteout, especially when the whole lung is whited out. And even like on image A, if you didn't have a tracheal shift there, we would just say that they have a left-sided whiteout. There's not air in there. So that's what we call a whiteout sometimes. Okay, and then see what's going on there.
That's a normal test X-ray.
That is normal. That's what we like to
You can see the ribs, you can see the heart, you can see the diaphragm.
Exactly.
There's no spots in random places that shouldn't be there.
Exactly. All the things we like to see. How many ribs should we see on a chest x-ray?
10.
About 8 to 10. And what should we have the patient? Well, obviously we're not taking the chest x-rays, but we can assess the quality of the x-ray by making sure that we have all these things in place. So should the patient be inhaling, exhaling, or holding their breath, breathing normally during an x-ray? What should they be instructed to do for a good quality x-ray?
Hold their breath.
hold their breath, okay? Because that's how you're gonna get that good expansion, and you're gonna get to see 8 to 10 ribs. What if the diaphragms were flat on a chest X-ray? What would that indicate?
Hyperinflation.
Hyperinflation, exactly. So like I said on the video that I sent you, I want you to go through and identify the structures, how you know that what structure is which, and I gave you a little list. But, and what's the significance of those structures being out of place? So like if you saw your diaphragms are here, of course. Okay, so remember back from 210 that although we call it a diaphragm, it's actually two diaphragms. You have this hemi-diaphragm. So you have left and right, and of course, which side is higher? Because this is flipped. Keep that in mind.
The right side.
Your right side is higher. Okay. So, and should give you a little indicator here telling you which side is which. So this is your patient's left side. That's what that little L means. Okay. So, you know, that you should be able to identify your right and left hemidiaphragm, that you should be able to count your ribs, that you should be able to see your vertebrae. And that's how you can tell where your carina is, that you can see your clavicles. You'll be able to identify lines like your ET tube, like your tracheostomy tube, even sometimes PICC lines, pulmonary artery catheters, things like that, by these different anatomical landmarks, as well as identifying, you know, the organs. What does the heart look like? Is it enlarged, right? We can see cardiomegaly on a chest X-ray. We can see cardiac tamponade on a chest X-ray. So we can see lots of different things in that realm as well. So those are, in addition to just evaluating the lung tissue, do you see consolidation? Do you see infiltrates? But we can also find other issues. Sometimes people go in because they're, you know, think they have pneumonia. They do a chest X-ray and they find that their heart is enlarged. So you can find out different things like that as well. Okay, any questions about the images? All right. So you were asked to define the terms and acronyms in great detail as they relate to radiography and imaging and how they relate to specific diseases. So let's see. AP, CXR, what does that mean?
Anterior posterior chest X-ray.
So what does that mean as far as who shoots the X-ray? Like how is that different from PA?
Well, it's a portable chest film, and the cassette is placed behind the patient,
Mm-hmm.
and the beams are sent from the front to the back.
Right. So typically we use this type of X-ray for patients who are immobile. So a lot of times those who are intubated on a vent in ICU, we are not going to take them down to X-ray, right, to get the image done. The X-ray people are going to come to them. They're going to do a portable X-ray. They stick the film or the cassette. They lift them slightly, stick the film or the cassette behind them, and they'll put the machine in front of them. So sort of like if the X-rays that they do when you're at the dentist, and they take the thing and they put it over your mouth and they shoot from the front of your face to the back of your head. So that would be considered an AP, or an anterior posterior chest X-ray. So again, this is usually reserved for people who are immobile, and that is the opposite of a PA chest X-ray, which of course means posterior anterior, meaning that your light source will be behind the patient. Okay, so usually this is if you've ever had a chest X-ray done and you've done it like in an outpatient clinic or even in an emergency room and they had you go to the X-ray area, you had a PA chest X-ray done. Which is the preferred method?
The PA.
Why?
Because then you're getting it minimizes cardiac magnification.
Mm-hmm. So you're going to get a better quality chest X-ray if you do a PA X-ray. When you do an AP, you tend to get shadows around the heart. It starts to look like that the heart is enlarged. It can distort the structures. So the better quality is actually a PA X-ray. And then your reading, you also found that there's a lordotic X-ray, apical X-rays, and other types as well, which I'll show you a picture of later. Okay, so number 3, what is a chest X-ray or chest radiograph? And what's the other term that can be used the other term that can be used for chest X-ray as well? Anybody get the other term?
Chest radiograph?
And there's another term that's not listed here. It's a rotinogram. So you'll find that in your reading. You may see that term used in lieu of chest X-ray or radiograph or CXR. So make sure that you find it in your reading, write it down so that you can identify it. Okay. So why should a chest X-ray, a chest radiograph, a CXR be obtained? What are some reasons that we might suggest that a patient have a chest X-ray done?
Provides important info about the status of the lungs.
Right.
And if the patient is in distress, you shouldn't wait for the X-rays to come back. If you know that it's like a pneumothorax, the treatment should be done instead of waiting and causing more problems.
Right. So care should not be delayed in order to get the results back from a chest X-ray. Most of them are portable and electronic nowadays anyway, which is a good thing, which means that as soon as the tech takes the image, it shows up on a screen. So even in the hospital, you'll see that a lot of times the doctor is waiting outside the room for the X-ray tech to come out of the room so that they can go ahead and evaluate the chest X-ray and move on from there with, the plan of care. So what are some other reasons? What are some signs and symptoms that might, because you'll be in that position as an RT in less than a year. So what might you see from a patient that might make you call the doctor and say, I think we need to get a chest X-ray? If somebody else other than Amanda help her out. If she's carrying this load all by herself. Hemoptysis. Okay, yep, that might be a good reason. What else?
Unexplained dyspnea.
Unexplained dyspnea, is that what you said?
The newer unexplained dyspnea.
Yeah, because what could show up on a chest X-ray that would explain that dyspnea? What are you thinking that you might see if the patient is dyspneic?
Atelectasis.
Okay, because the atelectasis. What else?
Pneumonia.
Yep. What else?
Pneumothorax.
Okay, pneumo. What else?
Could be even the heart side. The heart
Yeah.
size, like the cardiac tamponade, that's going to cause pressure from the heart. It causes your not to breathe completely.
What other cardiac problem might cause a patient to have shortness of breath? One that we talk about all the time.
Hypoxia, hypoxemia.
A heart problem.
Oh, heart problem, I'm sorry.
A heart attack?
You see that on a chest X-ray?
No.
If the patient has CHF, are you going to see any indication of that on a chest X-ray?
Oh, yeah.
Fluid retention.
Yeah.
Oh, yeah.
What is that called?
Pleural edema.
Pulmonary edema. Yeah, they get fluid, that fluid backs up to their lungs, and you can see pulmonary edema on a chest X-ray for sure. Yep. So any of those things might show up on a chest X-ray. That could possibly explain the patient's dyspnea. They could have a huge tumor in their airway, right? That would show up on a chest X-ray. We would have to investigate further, just like if the patient had hemoptysis, we probably do a bronch or something like that as well. They might need more invasive tests, or not invasive, but more additional imaging, CT, MRI, something like that. But a chest X-ray is usually the quickest, easiest way to, for your first imaging of the chest that you would get. Okay.
Now, would a tumor show up white, like if you had like calcium deposits too that show up in the lungs?
Yeah.
It would show up like the white solid mass?
Yeah, not necessarily stark white, but it would not be black. So you would be able to see nodules or something like that in a whitish gray color show up on your X-ray.
Okay, so how would you know the difference between like if you had like like pneumonia on the bottom and a mass. Would
Well,
that just,
your mass is going to have clear borders, so it's going to be like a circle as opposed to splotchiness that are infiltrates or a definitive line if you have atelectasis or pneumonia or something like that.
oh, okay.
Unless it's a huge mass. And in that case, again, that's why they would still do further imaging because the chest x-ray isn't going to tell you everything you need to know. And a lot of patients, like I said, they go in for, routine stuff and they say, we found something that looks suspicious on your chest x-ray. Let's do a CT.
Right.
Because they really can't tell for sure at that point, or even a bronchoscopy, because that way they can go in and visualize it and take a biopsy and figure out exactly what it is.
Right. Okay.
Okay. But your chest x-ray is kind of your first line of a chest, a picture of what's going on inside of the chest. So again, your patient should be inspiring, should be holding their breath. We can also, well, we don't take them, but there are also sometimes images taken during expiration. What would be a reason to take the film during expiration?
Is that the course crackles that were?
No?
Would that check for diaphragm? Like diaphragm movement? Like to show where the diaphragm would be placed after expiration?
No?
Well, on expiration, wouldn't that be your COPD patients? Because they're not able to get that, so we're checking for all that emphysema and all that.
No. So it would be, you can a lot of times see the location of foreign bodies and also assess to see whether or not the patient has a pneumothorax on expiration. Because if on expiration, you're still seeing a bunch of white in the lung, right? You should see less white, you should see less ribs if your patient has blown out all of their air. If you still see that one side is full of air, even on expiration, then that would indicate to you that they have a pneumothorax. Flo, I think maybe where you were going with that is you can see that if there is still hyperinflation on expiration, then that could kind of contribute to indicate how severe their COPD and their air traffic is.
Mm-hmm.
Okay. Yeah. So they may do it in that case too, but a lot of times the inspiratory X-ray, and you see that those flattened diaphragms and you're counting more than 10 ribs is usually enough evidence for us, along with things like your ABG, PXE, stuff like that. Okay. So number 4, a lateral neck and lateral decubitus X-ray. What is that?
It's a lateral neck X-ray that can be used to determine croup or like epiglottitis.
Mm-hmm. So what does the lateral part mean? Lateral indicating that
the left side is pressed against the cassette, and the beam is going through the right side.
okay.
And it's and then they want to make sure you have your arms up above, so they're out of the way, so you're not trying to you don't see a humerus in your lungs, and it also helps to minimize cardiac magnification too.
Right. So anything lateral just means that it's from the side. It can be either side. Okay. But think about your body directions back from unit 1. We learned that lateral are your sides. So lateral X-ray just means that instead of them taking it AP or PA, they have you turn to one of your sides. Sometimes they'll do both sides because if there's a mass or something like that in the right lung, then they want to check it, or in one lung they may want to check the other one too to make sure that there's not an identical mass on the other side. Okay, so lateral just means that it's a side view. Okay, so lateral decubitus means what?
That they are laying on their side?
Right, that they're lying down. So they're not standing. Instead, you have your patient lying down, lying on their side. Okay, and what would be a reason to get a lateral decubitus X-ray?
Pleural effusion?
That's the best way to tell if your patient has a pleural effusion. Why is that?
Because if it's fluid,
Fluid's
those
gonna transfer.
move.
Exactly, because atelectasis, pneumonia, all that is going to look the same on a chest X-ray, right? Usually it's in a lower lobe, especially if it's a lower lobe issue. If it's in a lower lobe, it's going to be some white stuff at the bottom of in the base of the lung, right? Lower lobe. But if that patient, so you're going to see the white when they're upright. But if the patient turns to the side, that fluid is going to move as they move. Okay, so that's why a lateral decubitus X-ray is the best view to identify a pleural effusion. Okay, why would you get a lateral neck X-ray?
For the croup and epiglottitis.
For croup and epiglottitis. What are you going to see on that lateral neck X-ray if the patient has croup?
The steeple sign.
Steeple sign, right? And what if they have epiglottitis?
The thumb sign.
Thumb sign. Yep, very good. All right. So number 5, Andrika, what'd you get for a CT?
A scan that provides detailed images of internal organs.
Mm-hmm.
I got it. It stands for a computed tomography.
Mm-hmm.
It's a specific type of X-ray device.
Okay. So does it aid, what does it aid? Why would we opt for that instead of a chest X-ray?
I'm not sure.
Okay, well, think about what you said. You said it provides what now? A more detailed?
Detailed images of internal organs, but when we do a chest X-ray, we're looking at the internal organs as well, right? Like,
Mm-hmm. But it's a more detailed view.
so is it just like a better image, but it's the same view?
Mm-hmm. Well, and you can get different views. So have y'all ever seen, and have y'all ever seen a CAT scan machine or CT machine? Okay, so the patient kind of goes into it and it does a cross section. So they get, it like slices the body into very thin slices. And that way you can see a lot more detail. You can start to see those bones, the soft tissues, the organs, the muscles. You can evaluate tumors. You can measure them better. You can see exactly the location, things like that. So like you said, it's a more detailed view. So don't give up that quickly. You said it. Let's dig into that a little bit. So yeah, it's a more detailed view. Like we said, you might do something weird on a chest X-ray. The doctor might identify something weird on a chest X-ray, and they might say, let's do a CT so that we can confirm what we think we're seeing on the chest X-ray, right? There's a lot of different
That's
things.
like, why do an X-ray? You might as well just do a CT scan and go full out and see what you're gonna see anyway.
And sometimes they do, but if you work in the emergency room, how likely is it that they're going to do an X-ray versus a CT? Which one is more expensive? Which one requires more resources?
I'm sure the CT scan, since it gives a more crystal clear image.
Exactly. So if I don't know really what's wrong with you, I'm gonna throw you over to get an X-ray first, and then if something weird shows up, that's when we'll do a CT. Spend all that money, make sure your insurance is gonna cover it, make sure that if not, the hospital's gonna eat it, versus going straight to CT.
Okay.
Okay.
Isn't it sometimes quicker to get your X-ray because you have a portable?
Exactly.
Sometimes people can't get to the bed. You got to transport them over to CT. It's going to take some time. They need something quick.
Exactly. So it's the easier, quicker, cheaper, more attainable option, right? Even your smallest, most rural hospitals have an X-ray machine. They may not have a CT machine though.
That's like if you go to urgent care, you can do an X-ray, you can't do a CT.
Exactly. So you can get a 3D image. It helps the physician diagnose and figure out if surgery is needed, another treatment is needed, if the patient needs radiation, what dosage even is needed, because they can figure out the density and the size of precise location of like a tumor or a mass, for example. So it gives you a lot more information, a lot more detail, but it's still using the X-ray technology. Okay. What is an HCRT?
The same thing, but just with more resolution.
Exactly. So that's the Mac Daddy of the CT. So that's where you got to have real good insurance if they're going to cover that one. So that's even taking it a step further than a regular CT. So it doesn't image the whole lung, but it will like zero in on certain areas as well. So soft tissues, it's really good in evaluating parenchymal problems. So what's the parenchyma?
The lower parts of your lungs where the gas exchange, so pretty much the area where your alveolar is.
So that's the lung tissue. That's just a generalized term for lung tissue. Okay. So if you have an issue with your lung tissue, then a high resolution CT can identify specifically what that problem is and not just say, oh, there's a mass in there. We can determine, or, oh, that tissue doesn't look right. Is it emphysema? Is it bronchiectasis? Is it ILD? What's going on? So it's just it's how we said that a regular CT slices the body into strips, so to speak. The slices are smaller, are even thinner with a high resolution CT scan. So it just gives you more detail. It's still the same X-ray technology, but it just can give you a better diagnosis of various lung diseases as opposed to being more vague. So notice that the further we're going down, the more detail we're getting. Okay. So again, you can't identify everything on a chest X-ray, but it's easy, it's quick, it's the cheapest. So the next step would be a CT, and then sometimes that's not even conclusive. So you could opt for a high resolution CT. Some hospitals, some doctors, depends on your insurance and resources and things like that too. They might opt straight for a high resolution CT. But those are the different options we have as far as using radiography technology in other forms outside of a simple 2D chest X-ray. So again, these are 3D images. It's going to give you a very detailed view of the lungs, the surrounding tissues, and figure out, do we need to go in there and get a biopsy? Do we need to go in there and remove this mass, or is it benign and not malignant? So, and of course, these are all non-invasive, meaning we're not sticking anything in the body. Okay. What's the CT angiogram?
It's used to diagnose pulmonary embolisms.
Mm-hmm. Right. So it's still a CT. You're putting the patient in a CT machine. You're using X-ray technology, but the angiogram specifically, or angiograph, specifically is going to look at the blood vessels. Okay. So that's what we're zeroing in on here. So usually the patient is injected with a dye, an iodine-based dye. We call that contrast. So you'll sometimes hear that they're having a CT with contrast. That means that they put dye in their veins so that they can show up easier on the scan, on the angiography scan. So that way we can see if they have a pulmonary embolism, which is what?
A blood clot in the lung, or not in
the vessels.
In the
right.
vessels.
In the vessels that feed the lungs, right? So we want to make sure that those are clear. So if we suspect a pulmonary embolism, and what are the signs that would make you say, we might need to send this patient for angiography?
If they have a history of blood clots,
okay,
or they're hypoxic and we're trying to give them O2, but yet it's still not getting any better.
Mm-hmm. Okay, good.
What if the patient if the patient says they're not feeling well, like they feel weird because it's like they don't really know how to explain it a lot of times?
Well, that's not necessarily a reason for a CT. I know what you're saying, because we talked about the other day how they feel that impending sense of doom sometimes with a pulmonary embolism, but that's not necessarily a reason to send them for that particular test.
Oh,
right. I've had moments where I'm like, I just don't feel right. I don't know why, but I don't know what it is. So that doesn't necessarily mean that I need a, CT of my vessels. But I get what you're saying though. So, but there's going to be those signs and symptoms like Amanda said.
It won't go up.
What'd you say? Yeah, that's what I'm saying.
It's not going up.
Right. And what is that called when we give a patient oxygen and they don't respond to it?
They're not ventilated?
No, ventilation has nothing to do with oxygen. Mallory, what's that term?
Is it refractory?
It's right at the tip of my tongue. Factory.
Wait, look at my arm. This is got my arm.
So then if they don't have enough oxygen in their blood, you give them oxygen, they still don't have enough oxygen in their blood, it's refractory what? What's the term for not having enough oxygen in your blood?
Hypoxemia.
Yeah, so it's refractory hypoxemia. Yeah, and that's because, I can fill those lungs with all the oxygen I want, but if the blood's not moving, the blood can't get to the alveoli to pick up that oxygen, drop off the carbon dioxide, it's not doing anything. Think back to Palm MMP, remember those units that we looked at? Where one was open and there wasn't enough blood flow, and then one was closed, but there was good blood flow. Which unit would that be if a patient had a pulmonary embolism?
Shunting.
What is the definition of shunting?
Shunting is perfusion without or in excess of ventilation.
Larry, will you mute yourself, please? So shunting is what now?
Perfusion without or in excess of ventilation.
Okay, so is ventilation the problem?
No.
No. So it would be
Okay, so it would be the dead space.
yeah.
The dead space unit, because you're having ventilation without or in
Yeah,
excess of perfusion.
Exactly. So this is what pulmonary embolism is a prime example of that dead space unit. Ventilation is fine for now. The patient's still breathing for now, right? But there's a big old clot that's keeping blood flow from going. So that was that unit where the alveoli was open, but the blood flow, the stream of blood flow beneath it was all little.
Mm-hmm.
And you saw that the blood going into the lung and leaving the lung was still deoxygenated. It was still venous blood because it couldn't pick up any oxygen.
Okay.
Or leaving the heart, I should say. It was still
Makes
deoxygenated.
sense. Makes lots of sense.
Yes.
Good. That's what we're going for, man.
Light bulbs.
I love light bulbs. They're my favorite. So, and then here are some pictures, because y'all know I'm all about pictures. So here are some pictures of a CT angiogram. So you see all the vasculature that kind of lights up on that CT. Okay. And so a lot of times with the CT, like we were saying, that it kind of slices the body in half. So you'll see these slices and they can go through, sorry, I don't know if I'm for y'all, but you'll see these slices. It's kind of like if you slice an onion and you look at each slice individually. So that's kind of slicing the body, and you can look at each slice one by one by one. So it gives you a better idea of what's going on with different organs, with different parts of the tissue, and even if there's like a nodule or something like that. So, and then with the CT angiograms, again, the focus is the vessels. So you can see, because of that contrast, because of that dye that's injected into the vein, all those vessels light up. So you can see if there's a blockage. So if there was a blockage in one of them, instead of it being white, there would be a dark spot in it. Mm-hmm. So that's what you would see with a CT angiogram. Okay. MRI, what's that? Nicole, what's that?
Magnetic resonance imaging.
Mm-hmm. And what's going on with that? Tell us all about it.
They're basically showing you imaging within your lungs.
Okay, you can do MRI of any part of the body, pretty much, right? Is it using X-ray?
No.
No, what does it use instead?
What do we use instead?
Mm-hmm. If it's not using X-ray technology, what kind of technology is it using to produce that image?
Just like the CT where they go on there.
I thought that was using X-ray. CT. It uses magnetic resonance imaging.
Okay.
It's a big, giant magnet. That's how you create that image. It realigns the hydrogen ions in the bodies, and as a result, we get pictures.
Okay.
So there are no radio waves. Well, actually, I'm sorry, it does use radio waves and it uses magnets. It doesn't use X-ray technology. So what are your limitations of an MRI? Who can't go
Well,
into
we
an
don't
MRI?
really use a jewelry, wearing a necklace or jewelry because it's magnetic.
Right. Mhm.
Yeah.
And with any of these
Yeah.
images, for the most part, it's possible we want the patient to take off jewelry just so it doesn't disrupt what we're trying to see. Like if the patient's got a big old necklace, chest X-ray, it's going to block some of our view. So, what else though? What's the huge thing that you should always remember? These patients cannot go to MRI. We would have to opt for a CT for these patients.
If they have a pacemaker.
They're having a pacemaker. Yeah.
Patients who have a pacemakers or any implant for that matter, metal implants, I should say, they have to go to MRI, or they cannot go to MRI, excuse me. They would, even if an MRI is more appropriate, instead they would have to get a CT instead, because what's that MRI machine going to do to that pacemaker?
It's gonna suck it out.
Rip it out of their body, through their skin and out of their body.
Yeah.
Okay. 99.9% sure I sent y'all a video of somebody putting a chair in an MRI machine,
A what?
Put it on what?
a chair, and all sorts of other crap. They just
Oh.
stuck in an MRI machine.
Did you just send it? 'Cause we didn't.
That's what should have been with your gas physics unit.
No.
Because we were talking about the importance of not taking your
I don't remember that.
well, we were talking about the importance of being careful with tanks in an MRI machine, or in an area where an MRI machine is, because it's metal.
No, I don't remember
So
that.
anything metal is going to, the MRI machine is literally going to try to suck it into the machine. Okay, it's a magnet. You ever had a magnet around any metal? They're attracted to each other. So you will have patients who are intubated, who are on a vent, that have to go to MRI. That does not mean that they can't go. That means that you have to strip down earrings, jewelry, anything that you might be wearing, because you're probably going to get the closest out of anybody to that MRI machine, except for the MRI technician, of course. But there's a special ventilator that has to go to MRI. You can't use a traditional vent. It has to stay a certain number of feet away from the MRI machine at all times. Your tank, usually you have to disconnect before you go into, there's different zones or areas, usually it's behind double doors, so zone 1 and then zone 2. So you have to take lots of precautions if a patient does have to go to MRI, to make sure that you don't create missiles in the MRI suite, because that would be a disaster. Imagine having a patient in an MRI machine and then your tank goes flying across the room and is sucked into that MRI machine with the patient and hits them all over the place on the way in. Not good. Okay. So make sure that you take the correct ventilator and make sure that you're taking all those precautions. The physician, the nurse, sometimes even you need to be double, triple checking the chart to make sure that the patient does not have any metal implanted devices that would prevent us from being able to use MRI technology. Okay. So, and usually CT is better. It provides more details than MRI anyway.
Yeah, as far as you're saying that too, for ours, like they won't allow the patient to even go to MRI to wait for their MRI or anything until they have the specific form filled out by the patient. Like if the patient can't fill it out, the nurse has to, and they'll bump that person if they don't have the paper done and go get somebody else. So the nurses always have to run around, make sure that's done ahead of time, like they let them know.
We can't take that chance. We can't. And if it's not known, like if your patient is not verbal, now obviously, how would you know that a patient has a pacemaker implanted, for example?
The scar.
Okay, what else?
It has a bulge above the
You
skin.
can feel
You
it.
can see it,
Yeah.
right? You can see it. It's like a deck of cards or a hockey puck right under their skin.
Yeah.
You can see it. You can feel it. It is there. So obviously there's that. So even if you have an unresponsive patient, but sometimes if they've had like a knee surgery or hip surgery and there's any type of metal or metal plate in their head, something like that, that's not always as obvious. So if you're not sure, then, or if the physician is not sure, then usually they'll just go ahead and opt for CT because it's the safer option rather than not knowing, or, you know, like you said, well, they have to have paperwork filled out, and if it's not filled out, why would we take that chance? So nope, not yet. So
And some people have a, I forgot what it's called. It's a, with their bladder. It sort of does the same thing as the pacemaker. I forgot what it's something in their bladder. And the nurse kept telling us that the patient didn't have that. Kept saying, "Oh no, she doesn't." And then the patient asked the patient. Patient said no, but we kept seeing it in their it kept messing with their because we were trying to do the strips, so it kept messing with their strip. And we kept asking, "You sure? You sure? You sure?" And then the patient finally remembered, and then went all the way in their chart to say, "Yeah, they did have that." Because it was just like messing. So that would have been something that would have really been bad if they would have had an MRI and had that and couldn't remember, and the nurse didn't make sure. So
yeah, and even if your patient is alert, but they're a poor historian, like in that case, poor historian meaning not that they don't know, you know, their American history, that they can't remember their own medical history. And a lot of patients are very poor historians. They've had a lot of procedures. They've been in and out of the hospital a lot, or they're just older, they're confused, whatever the case may be, and they don't remember. So, you know, it's better to err on the side of caution in all cases. Okay.
we're new to the hospital, new to the area, and not know anything, and the hospital has no information.
Exactly, absolutely. So, you know, if they didn't have, if they've never been to that hospital before, there's nothing in the chart for that patient. So there's that too, which is why a lot of times we have to rely on the patient. So number 9, ultrasound, another type of imaging. Tell me all about ultrasound, Taylor.
It's sound waves. We use high frequencies that's above human hearing. Harmless to humans, including like fetuses and all that. It's portable. It can be used for guidance of needle placement during thoracentesis, catheter placement during chest tube, needle placement during central vein line placement. Visualization of ET tube placement, assessment of echocardiogram.
That's a big one. Yeah, good. So, and I forgot to mention, but I'm sure you guys read, and if you didn't read, you already knew this. Obviously, with CTs and CTs and chest X-ray, that can cause radiation for the patient, increased levels of radiation to their body by doing it. It's a radiograph. There is radiation. Every time they get an image done, they're exposed to radiation. Even in the hospitals, a lot of times patients who are intubated, some hospitals, they'll do a chest X-ray every single morning to make sure that the PC tube is in the same spot. But of course, every time you do an X-ray, you're exposing your patient to radiation. Same thing with the CT. The nice part about an ultrasound is that there is no radiation exposure. It doesn't even use a magnet. It uses sound waves. So what's the other name for ultrasound?
Sonogram?
Sonogram or sonography. So that's the type of science that's used to create this image. It's not via magnetic resonance like MRI. It's not via radiation like you have with the chest X-ray or the CT scan. The other nice part about this is that it is real. You get real-time imaging. Okay, so with the chest X-ray, it's a snapshot. It's a still shot. That's it. It's a picture. Ultrasonography is like a video. This is the nice part. So you can see big structures move, like we talked about the other day with an echocardiogram. You can see the heart. And actually, I just saw that, I guess the new sonography people posted a video of the carotid artery from the school yesterday. But anyway, so you can see the opening and closing of vessels. Like Taylor said, you can see fetal movement. You can see you can use it for thoracentesis. You remember we watched the thoracentesis video, and the doctor assessed the area to make sure to see where the fluid was before he placed the needle. So PICC lines can be placed. There are like line nurses, PICC line nurses in the hospitals. You may have come across them. We like to stop them so we can watch them place lines, because that's always fun. And they'll show us the vessels. With your arteries, you can see them moving. So a lot of times they'll place a PICC line in the neck. And so they actually ultrasound the neck so that they can see exactly where to put the needle and put their catheters in. So multiple different reasons to opt for an ultrasound, but most likely in the clinical care setting, it's going to be for an echo. But they can also ultrasound any part of the body. I remember one time I had to have my liver ultrasound because I'd taken aspirin before blood work or acetaminophen, so my liver enzymes were elevated. So then they had to ultrasound the liver. So they can ultrasound anything, really, and get a more detailed image. And it's also, like Taylor said, it's portable. It's more accessible than things like a CT or an MRI. Okay. VQ scan, what's that? Ouchie.
There's ventilation perfusion scan.
Mm-hmm. Tell me more.
This scan is performed either for the blood flow in our lungs,
Okay.
and this diagnosed pulmonary emboli.
So we've
This
all
can
heard. Go ahead, I'm sorry.
a low risk of radioactive substances.
Mm-hmm. Okay, yeah. So we've all heard of VQ before, right? VQ ratio, meaning ventilation versus perfusion. So we can look at how much air is getting into the lungs versus the blood flow. So this scan actually looks at the ventilation compared to the perfusion in our lungs to determine if there is a pulmonary embolism, okay? So this is another test to determine whether or not your patient has a pulmonary embolism, okay? So most of the time nowadays, it is not the gold standard, but you will often be asked questions about what is a VQ scan for. If you suspect that the patient has a pulmonary embolism, what test could you suggest? VQ scan is still relevant for test taking purposes, so keep that in mind, okay? So again, blood clots, even air embolisms in the lungs. In CART, there's a picture. It looks like little scattered dots. That's what the actual image looks like. So if you look in CART, you will see a picture of what the results of a VQ scan will look like. A lot of times the patient inhales xenon or some radioactive gas so that the results in the images are clearer. But the purpose of getting a VQ scan is to detect a pulmonary embolism. What's a PET scan? Open to the floor.
Position emission tomography scan is an imaging test that helps reveal how your tissues and organs are functioning.
Mm-hmm. Good. Yeah, so positron emission tomography or PET scan, it's a type of nuclear medicine. So sometimes you'll even hear in the hospital, oh, they went to nuke med or nuclear medicine. So this is a type of nuclear medicine imaging. And usually it's to observe the metabolic processes in the body. So a lot of times a PET scan is a research tool or a medical diagnostic tool. A lot of times they'll use these for cancer patients. So again, we want to see how tissues are acting, how metabolic processes are happening. We don't want just necessarily a snapshot. So more commonly, PET scans are used in oncology patients. So to evaluate tumors, to see if tumors have metastasized, things like that. What does metastasize mean, by the way?
To make the test.
Multiply the size.
Hold on, Andrew, what'd you say?
I said, does it mean to make it bigger?
No, what'd you say, Amanda?
It's where the cancer has spread throughout the rest of the body.
Right. So, and not necessarily even throughout the rest of the body, but from one is you may have started out with one type of cancer, and then you start to see that it spread to one or more areas of the body. So I think I told you guys a story about a patient who came in to the hospital for back pain, and it turns out his back pain was caused by lung cancer. He had the lung cancer first. It had metastasized to the bones in his back, to his vertebrae, and that's what it caused the back pain. So really, it's the spreading usually of cancer is what that means. So you can start out with one type of cancer and end up with cancer in a different area because it's spread or it's metastasized. So they'll even say metastases means the same thing. Okay, so that's what that means. So PET scan is nuclear medicine, and it's typically used in the treatment or diagnosis for oncology patients or cancer patients. Okay, what does the ground glass appearance indicate? What does it look like? What does it indicate?
It refers to a shadowy pattern seen on cultural plates that is midway between the greenish hue of alpha hemolysis. So is it greenish?
No? Is that from Google?
No, I found it in a different little book that you got, but a book that somebody else gave me.
Okay. Because keep in mind that we're going to see the ground glass. We're kind of moving now from images to things that you would see on images, right? So on all our imaging, it's going to pretty much be like black and white.
Shadowy.
So you won't necessarily see color show up. It's going to be more so what the pattern looks like. Does that make sense?
Okay.
So it looks like literally if you've ever had glass and you like a mirror, and if you were to take something really hard and you try to grind it up and how it goes into little bitty pieces all over, that's what this mimics, or that's what this looks like in the lung field. So you can pick it up on a CT scan, like you see here. So this would be an example of a CT scan. You see the slices, and you see how it looks like if you shattered a mirror. See that? So it can indicate different diseases like pulmonary opacities in the lungs. It can be seen if a patient has alveolar wall inflammation or thickening. It can be seen, with inflammatory diseases like interstitial lung disease, ILD. So a telltale sign that a patient has an inflammatory disease of the lung or interstitial lung disease is that they have that ground glass appearance in the lung. Okay. And again, it can be picked up on CT and MRI as well. Sometimes even chest X-ray, and of course, then they will do more detailed imaging. But usually it's indicative of an inflammatory issue within the lung, some type of inflammatory disease. A lot of times patients who have this ground glass appearance are diagnosed with interstitial lung disease. Okay, so again, now we're kind of moving on to things that you would see on a chest X-ray and what they mean, what disease process they mean. Okay. And it's caused by the partial filling of the air spaces. So again, this interstitium, the tissue within the lung, it starts to thicken. It can cause those alveoli to collapse. These are all things that happen with patients who have interstitial lung.
Bless you.
Bless you. Okay. Fluffy opacities, what is it and what does it indicate?
Indicates the pulmonary airspace, like a disease of the pulmonary airspace.
Okay, like what?
Like pneumonia.
Okay, yep, could be. So we sometimes will refer to fluffy opacities as hazy or diffuse infiltrates. So we know that lung tissue should be, filled with air, should be dark on a chest X-ray. Fluffy infiltrates or hazy opacities, and they use those terms interchangeably. They are kind of like clouds that show up on the lung. So you ever looked at a sky and the clouds are not like those big fluffy clouds, but instead they're kind of scattered all over the place. You see kind of like cobweb in the sky. Does that make sense? So if you look at these chest images, you see that it's not just black or dark gray with ribs, but you see kind of this haziness, this fluffiness, these cloud-like formations. Everybody see that?
Yes.
Okay. So those are what we call infiltrates or opacities. Okay, so anything that's opaque means what? or even radiopeg.
It's not more black, but those are more like
Other one, more white. It means more white, not very see-through, that sort of thing.
So if it's more opaque, it's going to be more solid white
Yeah,
or
and no,
whiter. I
not
guess.
necessarily solid, because they're fluffy usually or hazy.
Right. Okay.
Yeah, but more white, that sort of thing. So kind of still you have, this is not a whiteout. This lung is still filled with air. You just see kind of these splashy areas. Does that make sense?
Yeah,
That's what
I
I'm
think
kind of
it makes more
describing.
sorry. I think it makes more sense what you said, like cloudy, because like when you're in the morning, like fog, how it looks kind of hazy and foggy.
Yeah. So, and this is kind of like with breath sounds, how you had to associate the description with the sound. Here, you're having to associate the description with the image. Okay, so this is what a fluffy infiltrates, and there's different types of opacities or infiltrates. This is known as just reticular, meaning that it's more liney. Oops, sorry. This middle one is called a nodular infiltrate, which just means that it's more dotty. And then the reticular nodule infiltrate just means that you have lines and dots if you look really closely to it. Look really closely at it, I should say. So usually it indicates an airspace disease, like Amanda said, it can be a pneumonia, aspiration. The patient has aspirated, and now whatever they aspirated is showing up as all fluffy and as opacities throughout the lung. Because usually, you know, if they aspirate some juice, it's not going to be one blob of juice in one space. It's going to disperse a little bit. So it could also indicate pulmonary edema as well. So infiltrates, haziness, and a lot of times on a chest X-ray, that's what we'll see. So we'll see that they have like these kind of cloudy areas of their lungs, and then again, we have to look at the whole picture and figure out, well, what is it? Is it because of a pneumonia? Do they have a fever? Do they have purulent sputum? Is it because of aspiration? Is this a stroke patient, right? Who maybe is supposed to be on thickened liquids and they refuse to drink thickened liquids at home, and now they came in and their chest X-ray looks like this. They have a fever, they have foul-smelling breath, they have difficulty swallowing. That would all indicate that it's an aspiration pneumonia as opposed to a bacterial or a viral pneumonia, right? Does this patient have a history of congestive heart failure? They won't take their Lasix. So now they have pulmonary edema. Okay? But you'll see these fluffy, cloudy-like areas on a chest X-ray. Okay, so 14 bronchograms. Bronchograms are air-filled bronchus. So the bronchus, of course, are the airways. So you will see that the airways are filled with air, but then around that, you'll see an airless lung. So areas of the lungs that are not filled with air. So that's going to be white, of course. So then it starts to outline these air-filled airways. Okay, so this is a really good image of that. So this would be like a CT. So you see that this part of the lung is not filled with air. It's white, right? Light gray is not black. So we know that it's not filled with air. However, this airway is filled with air. So then you kind of get an outline. Does that make sense? Okay. So that's what we call an air bronchogram. So sometimes you'll see this with pneumonia or different consolidative lung diseases, because you have something, consolidation density, something like that in the lung space, but then the airways are still filled with air. So again, that's air bronchogram or air bronchogram sign. What are your curly V lines? Number 15.
It's used to diagnose pleural edema.
Pleural edema,
Yeah,
pulmonary edema.
yeah. I don't know why. But I have it written down as pulmonary edema.
Good. Yeah, so they're basically straight lines. Usually in the bases of the lungs is typically where you'll find these curly V lines. So typically, again, straight looking lines in the bases of the lung, and they will typically indicate there'll be a sign of pulmonary edema. So there's a picture of it down here at the bottom. So it's kind of hard to see up here, but there, you can see it better on this one, but I don't know what it looks like on y'all's pen. But it just looks like straight lines, like somebody took a pen or something, usually they're darker, and they just drew little squiggly lines towards the bottom of the lung. Okay, so that's all they indicate. Okay, bat wing appearance. This is one that you're gonna hear and see over and over and over and over and over again. Mallory, where'd you go? You must have known, felt it in your bones. I was about to ask you what bat wing appearance is.
It's pulmonary edema.
It is a telltale sign that your patient has pulmonary edema. So you're gonna see those fluffy infiltrates, those hazy opacities, but you're gonna see that they're kind of congregated in one area up towards the hilum. What is the hilum?
The vessels go into the lungs.
Right, so the root of the lung. So, and where is it located?
In the inner part of the lungs, the middle part of
Where's your inner part of your lung here?
lateral, the medial sternum.
Okay, so towards the midline. So up in this area, because that's where your trachea branches off, where it bifurcates, where the right and left mainstem bronchus go into the lungs, where those large vessels from the heart go into the lungs. So that's right at the area of your mediastinum. So this is where your hilum is located. Okay, so notice that you have those cloud-like, fluffy, hazy infiltrates, opacities, whichever you prefer to use. But look at where they are. They're all kind of hanging out right up here by the hilum. Does that make you know, this is getting a little low, but especially on this side, it's kind of hanging out on the hilum, and it's bilateral. What's bilateral mean?
Both sides.
Both sides. You don't have just those fluffy infiltrates over here and nothing over here. They're on both sides. It's a bilateral issue. So they kind of outline the bat over here, but so we call that a bat wing appearance. So again, you're going to have those fluffy infiltrates, those hazy opacities, whatever you want to call them, but they're going to be bilateral. They're going to be up near the hilum. And that is a telltale sign that your patient has pulmonary edema. So you might see a test question that says something like, you're on chest x-ray, the patient presents with bat wing appearance or bilateral fluffy infiltrates. May not even say bat wing appearance, but if it's describing to you bat wing appearance, it's the bat wing appearance. They have crackles. They have crackles on auscultation. They are coughing up pink frothy secretions. They have a history of hospitalization requiring cardiac cath lab and Lasix, but are non-compliant with their treatment. What did I just paint a picture of to you? A patient who has left-sided heart failure and a patient who is now in fluid overload because they didn't take their Lasix. So now they have pulmonary edema. Okay, but you see how it shows you the picture of the patient. What are the signs, symptoms, indication that a patient has CHF? That they have that they are on a diuretic, right? That they have pink frothy secretions, which is indicative of pulmonary edema. That they have crackles on auscultation, which is indicative of pulmonary edema. And then that other blaring sign was also that they had that bat wing appearance on their chest x-ray. So you got like 15 clues to know that pulmonary edema is what you're dealing with here, okay? But again, that telltale sign, a lot of times when pulmonary edema is the answer, the key word that you'll see is the bat wing appearance, okay? Some people call it butterfly wing or butterfly appearance as well, but bat wing is the more commonly used term. Okay, honeycomb appearance, what is it? What does it mean?
Widespread fibrosis and is defined by the presence of small cystic spaces.
Mm-hmm.
So,
Go ahead, I'm sorry.
No, you're fine. I was just trying to make sure I read that correctly because,
So literally on a CT scan, this would be an example of a CT scan, but on a CT, MRI, whatever, it would literally look like a honeycomb. So I don't know how well y'all can see that, but it's literally those little circles like you would see in a honeycomb, like a bee's honeycomb. So that's what the appearance that you start to see on a chest X or on a CT scan or other imaging. And it is usually an indication of lung fibrosis, pulmonary fibrosis, usually end-stage pulmonary fibrosis, pretty severe pulmonary fibrosis. So again, let's paint that picture. This patient has a history of, they might have a cough, might have shortness of breath, vague respiratory signs, right? On a PFT, their volumes and capacities are decreased. Their DLCO is decreased, and they have honeycombing on their CT scan. What do they have? All those things are pointing to pulmonary fibrosis. Okay, any questions about kind of the examples that I'm giving?
No, I love it. It just like paints that whole picture of putting everything together.
Yep.
What that patient, not just, okay, this, okay, that, but then seeing this and then saying, oh, yeah.
Mm-hmm. And that's what I was even sharing with some of you. Notice that I'm sure you have that the structure of the questions are much different now because you got to use that noodle now because you are no longer little baby entry level RT students now. So you notice that the questions are a lot different, but yes, you might have to think more. Yes, they are wordier, but the nice part about it is that you're usually going to be given several clues to point you in the right direction. So like what I just said there, restrictive on a PFT, pulmonary fibrosis, well, restricted and decreased DLCO, you already got in your mind that it's pulmonary fibrosis, or you should. Plus, then they tell you, oh, by the way, they have honeycombing on their CT. It's pulmonary fibrosis all day. You don't have to second guess yourself as much, if you interpret the clues properly, of course. So, but that's what your honeycombing means. So whiteout, we've already talked about whiteout. That just means that if anything other than air replaces the air in the lung, then it's going to show up as white or light gray. So that could be water, anything that is denser than air. And so pneumonia, pulmonary, really bad pulmonary edema that is beyond just the fluffy infiltrates, hemorrhage, so that if there's blood in the lung tissue, you would see that as well. Anything that's not air in the lung, whether it's secretions, it's fluid, pneumonia, atelectasis, anything that is not air in that lung is going to appear white or very, very light gray on a chest X-ray. So again, you can have it bilaterally, meaning that both lungs are whited out, or unilaterally, meaning that there's just one side. We would investigate to see what's going on. Do we believe it's an atelectasis and we just need to hyperinflate? Do we believe that it's secretions and maybe we need to do a bronchoscopy and clean out their lungs, get out those mucus plugs that are maybe blocking off airflow to certain parts of the lungs? So depending on, other clues and other signs and symptoms, that would be how we figured out how to fix that problem. But of course, we would need to reinflate that lung somehow. Okay, any questions about that? You guys understand what can cause that and the treatment for a whiteout, whether it's bilateral or unilateral? Okay. So the meniscus sign, what is it and what does it mean?
It's a crescent-shaped inclusion of air surrounded by consolidated lung tissue.
Okay, so what does it mean? What does it indicate to you? What's wrong if you see this?
The most common cause is, and I'm probably completely going to butcher this, but it's aspergilloma.
What now?
Yeah, it's ASPERGILLOMA.
Oh, so a tumor caused by aspergillus is what you're...
Yeah.
Okay, so gotcha. And what is aspergillus?
It is like a clump or
Caused by what?
mold or something.
What's it caused by? It's a bug.
Huh?
It's a bug. Not a literal bug, but like a germ.
Allergens?
Didn't mean to alarm you. So actually, aspergillus is not so much associated with the meniscus sign. Aspergillus is when it's a fungus. It's like a fungusy organism that people can get in their lung, and it literally causes like a ball of yuck to show up in their lung, and they obviously have major lung issues because of that. But you'll see that as like a circular lump on imaging. So usually the meniscus sign, though, you guys remember like in middle school science class where you had those tall, skinny, long beakers, and you put water or whatever in them. What did the line look like at the top? Like wherever you stopped feeling it at, was it straight across?
No, it's kind of bubbled up.
Right. It was kind of a loop. It was kind of a dip, right?
Yeah.
So that's what the meniscus sign is. It's a dip. Okay. So typically when you put fluid in something, it has a little dip in it. It either is concave or convex. Okay. So in the
I know
lung,
the other way around.
what do you have?
Concave would be this way, right?
Mhm.
The cave.
I'm sorry. I wasn't
Convex
necessarily doing my fingers too.
Oh, sorry. I was
Yeah.
like, what?
Okay. Yeah. So, but you know, I'm saying that that's what fluid will do in a vessel. So, the meniscus sign is also known as the crescent sign. So now I know. So it's going to have that little dip. Okay. So okay. So usually the meniscus sign is associated with a pleural effusion. Okay. So yeah, you will sometimes see that curvature with that fungus ball, but a lot of times that meniscus sign is an indication that more than likely than it, because aspergillus is not super common. So if you do see a meniscus sign, more often than not, it's going to be due to a pleural effusion and not because of aspergillus. I'm not saying that it's not possible, because it is, but usually if you see the meniscus sign, it's going to be because of a pleural effusion. Okay? And that's just because that's what fluid does. That's what liquids do. They create that concave appearance, that crescent-like appearance. Okay. So any questions? So if you saw this on an upright x-ray, right? Maybe the patient had a PA x-ray. What should you suggest?
A lateral decubitus x-ray?
Very good. Yes. That they have a lateral decubitus x-ray, because that's how you can confirm that, because they colored this, but this is a better example. You see how this is just white, right? You see that? How this lung field is much bigger than this lung field. It's just going to show white if they're standing up. Can you tell whether that's snot, whether it's fluid? You don't know what that is. You just know that it's white. Now this, how it kind of dips in, tells you that's the meniscus sign. So that should be your clue that maybe I need to get a lateral decubitus. Because if you don't pay attention to that, you just see that it's white on a chest x-ray. Why can't that be pneumonia? Right? Why can't that be a right lower lobe pneumonia? Why can't that be a right lower lobe atelectasis? You don't know unless you pay attention to that small indication that it is probably fluid. Then you can go a step further, get a lateral decubitus, and roll out, determine if it is in fact a lower lobe pneumonia or if it is a pleural effusion. Does that make sense? Because of course, if it is pneumonia, you can put the patient on their side and it's not going to move because it's not fluid. It can't move. It's a solid, it's a density. But if it is fluid and you put the patient on their side, the fluid will move. So then you would know that what do you need to do if it's a pleural effusion? How do you treat it?
A needle decompression or thoracentesis.
Okay, so probably a thoracentesis. Remember the needle
Oh
decompression?
yeah, that's for the tension pneumothorax.
Right. So you could probably, the choice option would probably be a thoracentesis to evaluate that fluid, maybe even a chest tube. If it were pneumonia, what would you do then?
If after you asked them to do the chest x-ray, then it was pneumonia?
Mm-hmm. So you did the lateral decubitus, you didn't see a change in movement, so that will confirm to you, right, that it's pneumonia. Of course, we're looking at your patient as well. So if it was diagnosed as pneumonia, you wouldn't do a thoracentesis, right? Please no. So what would you do instead as your treatment plan? How do you treat pneumonia?
Medication.
What kind?
Inhale.
Relenza.
Yeah. No, not Relenza.
I'm sorry, that's for the flu.
It is.
Inhaled,
Steroid.
Well, it wouldn't
Antibiotic.
be you take it back.
What you say, AJ?
Steroid. Cortisone
Steroid?
steroids?
Yeah, probably not.
No.
What else you got? Tell us something that's different.
oh.
Depending on what kind of pneumonia would that, it wouldn't be
Figure out if
a
it's
pneumonia.
bacteria or viral.
Okay. Let's say it's bacterial.
Then they will get, and then if you want to do a gram, you want to figure out if it's gram negative or positive, and then it could be, then you figure out what antibiotic they need, then you go from there.
Okay, so let me just tell you, this is a little preview to Unit 3 infection control. Most people who are diagnosed with pneumonia, they never know what type of pneumonia they have. They put them on a broad spectrum antibiotic and hope it works. So most of the time, they go by your signs and symptoms to assume that it's either viral or bacterial. They may or may not ever get a sputum sample to figure out what type of organism is causing the problem.
Stop.
They just put you on a really broad spectrum antibiotic and
Stop.
cross their fingers.
Hope it works.
But
Yep.
then,
That.
couldn't that give them,
No.
like, C. diff if they're getting too many antibiotics in?
Could, or it could just not work, right? Because that organism isn't sensitive to their antibiotic. Could, maybe that's why we have all these resistant organisms, because we just throw antibiotics at everybody, but that's a whole different conversation. So yeah. So, but yeah, exactly. If we don't know what type of antibiotic they need, we might just not fix them at all, right? Or cause other stuff like C. diff.
You are now unmuted.
But that's what we do. So if you present with a fever, with maybe purulent sputum, chest pain, hurts when you take a breath in, dull breath sounds, maybe from this example that we're looking at here, right lower lobe, the chest x-ray shows white stuff in the right lower lobe. We assume you have pneumonia, so we're going to treat you with some antibiotics. What else can we do? What can RTs do if the patient is diagnosed with pneumonia to kind of try and help that situation?
CPT and right?
Aqua drainage.
And percussion.
Okay, yeah, postural drainage and percussion. We're going to try to beat the snot out of them, literally. Yeah, we can try that. What else?
Or we can give them
Hypertonic
hypertonic solution
What's that going to do?
that's gonna like break it up and produce sputum. Okay. Okay.
It's gonna make them cough a lot.
It's going to make them cough. And that might be a good thing, because if we turn them upside down and beat them real good and they cough now, they cough this stuff out, that's a good thing, right? Success. What else could we do?
In subject spirometry, so it doesn't get worse and cause more problems.
With that lung, that'll help them cough too. What else? What about those?
Encourage movement.
What did you say?
Encourage mobilization. Like
Yeah, you want to move it up, moving around, because that's going to, of course, help move around those secretions. They're going to be more likely to take a deep breath if they're up walking instead of laying in bed. You can try one of those PEP devices, right? One of those one of those secretion clearance devices, right? Which ones might work for secretion clearance?
Would that it would be the acapella?
Yep, acapella would. What else?
The
Flutter?
well, I know that's usually for the CF patients though.
But don't they have secretion issues?
Yes, the vest.
Yeah, because that's a form of PCP. What other devices though could we use?
Coughing. If they're
Yeah, well, that's gonna just increase the effectiveness of their cough. What other devices can we use?
can we
What about the flutter?
Oh, yeah.
not.
Yeah.
What about those adjunctive breathing techniques? What about unilateral chest expansion? What about a meta-neb? What about the virtual PEP device? We've got options, man. We got to use them.
We got lots of options.
We got lots of options. You got to know them as a clinician, and we need to encourage that they use. What about a cough assist?
Yep.
What about bronchium? That's not what we want to get to, but guess what? If nobody uses all that other stuff that we just didn't talk about at first, that we just had to dig deep for, guess what the patient's going to end up having done? Because and y'all know how I feel about that. I feel like all those other tools are way underutilized, and we have to bronch a lot more people than we should have to, because we don't use all those other tools that we have. There are a lot of them that we can use. Okay. So yeah, so that's the difference in how you would treat the different conditions. And you could do a lot of that same stuff for atelectasis as well, because it would present the same way as pneumonia on a chest x-ray.
I'm sorry.
What'd you say?
Can we suggest those to the doctor?
Absolutely, and you should. Mm-hmm. Now, some doctors are more receptive than others, but yes, that's why I say you as a clinician should know the options and should absolutely advocate for your patient and suggest them when they're appropriate. Especially to prevent a patient from needing a bronch. There was a patient he was at a car accident when he was like 16 years old, in and out of the hospital all the time, recurrent left lower lobe pneumonia. He was bronxed like 5 times in a week. They ended up traching him because they couldn't get his secretions out. And I'm like, why not give this man a cough assist at home? We were quiet coughing him and everything. He was in the ICU, left the ICU, went to the floor. Nobody was quiet coughing him. Nobody was giving him that aggressive pulmonary toileting. Ended up back in the ICU, bronch some more. Intubated, bronch some more. It's ridiculous.
Is that the guy we had in clinicals?
Yes. And then you remember the girl who was deaf and blind? They took her out of her CPT bed.
Yep.
She was barely getting her CPT. She was brought, I think, literally 5 times in 7 days. Intubated several times, extubated, intubated. All because who's doing the CPT? Who's advocating?
So what were her respiratory therapists doing?
I couldn't tell you. I don't work there. We were just visiting. So, but yeah. So don't be that therapist. That's why I want y'all to be great. Because it's a waste. It puts your patient in danger, right? That's an invasive procedure. They can get a different infection because they were bronched. Or not come off the vent because they were put on the vent to be bronched.
You are now muted.
So I don't know about y'all, but my conscience can't handle that. Sometimes I can't sleep as it is. I don't need that weighing on me too. So that's why I push you guys so hard to think and to advocate and to think outside the box and to, want to be the best you can. That's why. All right. Any questions? Okay. So number 20. Now let's put to bed this confusion about radiopeg and radiolucent. So the way y'all know me and our word association. The way I remember radiolucent is Lucifer. Devil, darkness is radiolucent. It works for me. I don't know. Not something I like. I don't like to go to that place often, but it helps you remember. Lucent is dark. Whereas radiopeg appears bright or white or light gray on a chest x-ray. Hence your opacities. Okay, and again, opacities, like we talked about before, will appear nearly white on a chest x-ray. It indicates something other than air. So it could be fluid, could be secretions, whatever the case may be, but it's not air. Okay, what does the deep sulcus sign mean?
An indirect indication of pneumothorax?
Yes, it is an indication of a pneumothorax. So basically, You remember what happens with the pneumothorax?
The lung collapses because of the pressure in the pleural space.
Right. So
Right.
something, most of the time, it's because something punctures the lung, and it causes that lung to kind of shrivel up. So in my mind, it reminds me like a balloon if you let all the air out of it, and how it becomes shriveled. So you have a shriveled balloon inside of your pleural space, inside of your rib cage, basically. So you can see the outline of that little shriveled lung on a chest X-ray. Okay, so that's what the deep sulcus line indicates. I don't know how well y'all can see this, but if you look very closely, or at least try to, there's a white looking kind of outline right there. And that's the little shriveled up lung. So obviously we know that the lung should be this whole space, right? Instead, the little shriveled up lung is here. Does everybody see that? Can you see that?
Yeah.
Or you understand what I'm saying?
Yeah.
So that's what the deep sulcus or
Hey.
sulci line means. It's an indication that the patient has a pneumothorax.
So it's over here in that little
Yeah.
corner,
Come
like,
here.
I mean, not like the corner closest to the mediastinum?
Right, in this where I'm pointing. Yeah, right.
Oh, okay.
So this is your heart. So right on the other side. Oops, right on the other side.
Okay, I see it.
6.
Okay. So plate atelectasis is just atelectasis, but it just looks like a flat plate. So if you look here, you see how it's kind of flat. So that's what we call plate atelectasis. It doesn't present symptom-wise to your patient as different type of atelectasis. It's not caused by anything different than regular atelectasis. It's just the way that it appears on a chest X-ray. It's usually flat across, so it's called plate-like atelectasis. Okay, what's a pneumomediastinum?
Present in the mediastinum when air leaks.
Mm-hmm. Yep. So, what should you have in your mediastinum?
Your heart?
Your heart, your trachea, organs, stuff like that. But that's kind of that little cavity that sits in between your lungs. So there shouldn't really be any free floating gas or air in there. And usually if there is, it's the result of chest trauma, and it's not a good thing, okay? So that air would need to be evacuated because it starts to put pressure on the lungs and can cause problems for your patient. So all a pneumomediastinum is just air or gas in that little cavity that contains your heart and your trachea and esophagus and all that good stuff. What is cardiac tamponade?
Compression of the heart caused by fluid collecting around the heart
Mm-hmm.
and preventing it from filling.
Would that be
Yes.
in the, what do I have here? And the a fluid in the pericardial sac
Mm-hmm.
or space?
Yes, so the pericardial sac, if you guys remember back from cardiac A&P, is that leathery kind of baggie that the heart sits in. Okay, so it's not that thin tissue that surrounds the heart. It's the heart is literally in an encasement, a loose-fitting, non-stretchy, leathery type of encasement that the heart sits in. That's your pericardium or your pericardial sac. Okay, there should only be a little tiny bit of fluid in there just to prevent friction as the heart beats. But if for some reason a lot of fluid accumulates in there, it puts pressure on the heart and your heart can't beat because, again, that sac is not stretchy. Okay? So the sac is not going to give, which is going to put more and more pressure on the heart. Okay? So that can cause death. How do we fix it? We watch the video.
Don't you have to go in and like suction out the fluid?
You gotta cut that pericardium. Mhm. You gotta cut the
Cardiac window?
pericardial window or pericardial centesis. And you can either use a needle, usually it's guided by an ultrasound, but they use a needle to aspirate the fluid out. Or the video that we watched, they cut a little hole, or it looks like a little square out of the pericardium and let all that fluid drain out. They suction some of it out as well. and that alleviates pressure on the heart. And we'll talk about.
It reminds me of, it was easier for me to just remember, like, you know, it's like a pleural effusion, but in the sac.
Exactly.
Like, being around the lung.
That's exactly, yep. Pericardial effusion, sometimes call that too. Yep. So on a chest x-ray, you might see cardiomegaly. You can pick up some cardiac issue on chest x-ray, and also obviously on ultrasound or echocardiogram, you would be able to see that as well.
Sit down.
Okay.
Down.
So the meniscus sign.
Down.
Oh, we already talked about that. Sorry, I'm going backwards. And also, what's the telltale sign on chest? You can even see this on chest x-ray that your patient might have cardiac tamponade.
Would it be where you would see the heart? It would be more opaque than.
Not necessarily color change.
You're gonna see the size of it. Wouldn't it shift a little bit more to the left because, you know, since the heart is, you know, or just.
It's not necessarily shifting, but it appears larger. So it's not that it's moved, it's just that more of it is covering the left lung because it's just bigger in mass. So we call that the water bottle sign, where the the heart starts to look like an onion. To me, it looks like an onion.
That's a very
Yeah. So that's called the water bottle sign. And that's an indication of cardiac tamponade. In your reading, I'm surprised you didn't also come across Beck's triad, which is 3 telltale signs of cardiac tamponade. We'll talk more about that later. Okay. So central lines, you can also see those on chest imaging. So central lines are often put in the internal jugular, okay, in the neck, or the subclavian vein, which is in the chest, or sometimes even in the femoral vein, which of course is in the groin. But they will often do chest x-rays to verify that the central line, so like we said, sometimes the PICC line nurses or special line nurses will place these lines and they want to verify that they are in the right place. So it's a more permanent IV option for meds to place fluids, to draw blood. So obviously the regular old IVs, if you've ever been in the hospital and got fluids or had surgery or anything like that, they can come out easily. They are more likely to get infected. So they're for temporary use, whereas a central line goes directly to the heart. So it can quickly deliver medications, and it's also more stable. It's dressed in a way that it's less likely to become infected as well. So they'll use chest x-ray a lot of the time to verify placement of it, and you can see the line there. This is a permacath, which is a different kind of line, but you can see the line there going into the vessels. Okay, sometimes they're in the upper arm as well. Okay. PICC lines as well. So PICC meaning peripherally inserted central catheter. And it's just a long catheter that they usually put in the arm a lot of the times, or the leg, and it goes near the heart for IV access. It usually stays there for a few weeks. So you can see they can verify placement with the chest x-ray for those as well. Another line that they can verify placement with the chest x-ray is what we call a Swan-Ganz or PAC, pulmonary artery catheter. So that catheter is what we place into it can go in through the groin, it can go in through the internal jugular vein as well, the carotid as well. And it ends up in the pulmonary artery, hence the name pulmonary artery catheter. So we can use that to measure different pressures of the heart to figure out if the patient is having a right-sided heart problem or a left-sided heart problem. So we'll often use that for those. And it's nice because we can verify placement that it's in the right place by a chest x-ray. So the problem with these, and we also, a lot of times the patients will have these done or have an x-ray done after they have a PAC placed, because if it's not threaded properly, it can cause a pneumo. So I've seen this test question asked a lot too, where it'll paint you a picture. Patient just came back from the cardiac cath lab, had a pulmonary artery catheter placed, Patient now presents with extreme dyspnea, shortness of breath, decreased saturations, decreased or absent breath sounds on the right side. What do you suggest? This patient has a pneumo, right? Tracheal shift, it might keep going on and on and on. But a lot of times, one of the risks of placing a pulmonary artery catheter is a pneumothorax. So that's why you want to verify that the patient does not have a pneumo after it's placed, and also verify that it's in the right place. So you guys will learn more about those next term when you get into hemodynamics. Okay, so 30, what is an intrathoracic balloon pump?
Helps your heart pump more blood.
Mm-hmm. So people who have left-sided heart, left ventricular failure specifically, right? They a lot of times have a decrease in their heart's ability to pump blood. So this device is inserted into the aorta. It's a long, thin catheter, and it just helps more blood get to different parts of the body. If the patient has severe heart failure or even mitral valve defect, regurgitation, it can help with that. It's a short-term solution. If you guys watch the old episodes of Grey's Anatomy, you heard about the LVAD. So it's similar to that, where it basically keeps the heart pumping until a more permanent solution can be figured out. Either they recover from whatever has caused them to have the heart failure, or, we figure out a better solution. Having valvular surgery to fix the mitral valve, whatever the long-term plan is for them. But you'll see those when, especially in ICU, people on the floor obviously wouldn't have these, but ICU patients, you may see a couple of them with this. And it's a little box, you can see the device, but it's a pump in the aorta that just helps increase cardiac output, it helps increase blood flow throughout the body. So interstitial disease, we talked about that. There are a lot of diseases that fall into that category. Sarcoidosis being one of them. A lot of your restrictive disease fall into that category. That just means that there are diseases that affect the lung tissue. They affect the interstitium of the lung, okay? So you would see kind of those fluffy infiltrates a lot of times, bilateral infiltrate, sometimes the ground glass appearance bilaterally as well on a chest x-ray. And any interstitial disease is just a disease that causes scarring in the lung. So the reason you see those abnormalities on a chest x-ray is because the lung tissue has actually been scarred. Okay, so again, any of your interstitial lung diseases will fall into the restrictive category. Okay. And this, of course, is a picture of sarcoidosis, which is interstitial lung disease is an umbrella term. One of the diseases that falls into that category is sarcoidosis. And as you can see, you see the abnormalities up here and the right upper lobe. Okay, hydrothorax is just another name for a pleural effusion. And of course, we know that that is fluid in the pleural space, okay, not within the lung, but in the pleural space. And we know that pleural effusion is just a catch-all or umbrella term for any type of fluid that may be in the pleural space. It can be blood, it can be chyle, it can be pus, it can be exudated fluid or transudated fluid. So that's just another name for it. And just another note on a chest x-ray, in a chest x-ray, so your patient sitting up, not a lateral decubitus x-ray, it can take up to 250 mLs to be in that pleural space before it even shows up on an x-ray. So a lateral decubitus is much more sensitive. Think about how much 250 mLs is. That's a fourth of a liter. That's a half of a water bottle. That's how much fluid would have to be in your lungs, minimal, for it to ever show up on an upright x-ray. So another sign I forgot to mention to you guys when we talked about pleural effusions before, the telltale sign of a pleural effusion is what we call blunted intercostal, I'm sorry, the train of thought just left me. A blunted intercostal, costophrenic ankle. That's what I'm trying to say, not intercostal. So if you look here, this is your costophrenic ankle. You see how the diaphragm and the lung creates kind of a sharp angle right here? You guys see this? Yes, no, maybe?
Yep.
Okay.
It's pointy, so in what you're saying, it would be more rounded.
Right. So let me go back to where we saw the meniscus sign. So you see how on this side is very sharp. That's called, again, your costophrenic angle. So here is not there. It's blunted, meaning that it's not sharp. That's what blunt means. Okay. So it's because you have that meniscus sign as well. You don't have that sharp angle created by the end of your lung and your diaphragm anymore. So even here, I don't know what they're calling this over here on the other lung, right? And their left lung on this other picture, but you still see that it's not this sharp angle like you have here. You guys see that? Instead, it's kind of fuzzy. Does that make sense?
Yes.
Yeah.
Okay. So again, another telltale sign, the meniscus sign, and also a blunted costophrenic angle is what you'll see. And those are all signs, a lot of those little jewels that indicate to you that your patient has a pleural effusion. So, and this is the difference between an erect or upright x-ray versus a lateral decubitus x-ray. So again, it takes a lot of fluid to accumulate in the pleural space before it shows up on an upright x-ray. I mean, look at how much lung space they have. Could you imagine? And keep in mind, this is not inside the lung, it's outside the lung. So it's pushing up on that lung. Could you imagine having this much of your lungs to breathe with? So obviously these patients sometimes are hypoxemic, they are dyspneic, sometimes they're using accessory muscles, they can't breathe well. It's very difficult and very hard for them to breathe, very uncomfortable for them to breathe. I mean, look at that. They're working with what, like a third of their lung capacity? So obviously that's very uncomfortable. And sometimes it takes this much fluid for it to even show up on an upright x-ray. And so again, even looking at this, I mean, yes, you have a meniscus line, but here it's not a real obvious meniscus line. It's kind of flat right here. You guys see that?
Mm-hmm.
So it may not be super evident that this is a pleural effusion. How is it so different from atelectasis or from pneumonia? At first glance, that may not be super evident, but you put that patient on the side and look at what happens to the fluid. The fluid moves too. So again, lateral decubitus x-ray is the best x-ray position to determine a pleural effusion. What are you going to see on the x-ray? You're going to see the meniscus sign and you're going to see the blunted costophrenic ankles. Okay.
I have a question.
Mm-hmm.
So a person who may have had, who maybe has a pleural effusion, how likely are they to have it again?
How likely are they to have
the pleural effusion again?
It depends on what caused it.
Okay.
So sometimes it can be because of an infection. The infection's gone. They no longer, get recurrent ones. A lot of times, though, people have recurrent ones because of cancers. So it just depends on why they have the pleural effusion in the first place. Obviously, it could be a hemothorax, and that could be because of trauma. It could be a chylothorax, and that could be because they have a GI issue that needs to be corrected first. And if not, they're gonna keep getting chyle in the pleural space. So they could have recurrent pneumothoraces because they have emphysema or something like that, or repeated chest trauma. So it just depends on what's causing it to happen. What is the procedure that you can do to prevent recurrent pleural effusions? Where they glue the two pleurals together.
Oh man. Isn't that the one with the powder?
Mm-hmm. What's it called? We just talked about it.
I don't remember.
I know. Keep forgetting that one.
Y'all gotta take time.
What's the first letter of the word?
P.
P. Oh. Pleural infusion?
No, sir. Pleural infusion. Is that what you said? I'm gonna put something in there. All right, I'll let y'all look it up. So fluoroscopy. Fluoroscopy is using X-ray continuously. Okay, so normally we talked about how X-ray is typically a snapshot, one picture, it's still of what's going on in the lungs. So they actually have fluoroscopy guided bronchoscopies now, where they actually it's continuous X-ray, and that way they can figure out exactly where they need to go, exactly what they need to biopsy and things like that. So fluoroscopy is just, again, it's using X-ray technology, but you get real-time imaging, so you can see continuous movement, continuous motion of those structures that you're looking at, but via the same science that creates X-ray. So obviously, if you're in fluoroscopy, if you're in one of those procedures, you need to wear lead. So CT too. So they put the lead aprons over you to make sure that your internal organs are not exposed to high levels of radiation. Okay, so they call it a super dimensional bronchoscopy, and that one is usually for fluoroscopy lead. So hopefully you guys will get to see that at some point in your life. The other one is called an EBIS, and that one is actually where you have a bronch and it's ultrasound guided. So they'll actually, if they have to go in and do a biopsy, we watched the video on that. I think it was supposed to be an EBIS, but then they found a big tumor in the airway. So they were prepared to do ultrasound guided bronchoscopy to figure out exactly where, the abnormal or abnormalities are, see exactly where they need to take a biopsy from. But sometimes, there are limitations, like if they find severe abnormalities that block the passageways and things like that. Okay. So cardiac catheterization, we say that they're going to the cardiac cath lab. And that's the diagnosis. The catheterization is a diagnostic procedure. They put a catheter usually in a large vein and then advance it until they can get to the heart. That's kind of a blanket term for the procedure of placing the pulmonary artery catheter. So a cardiac catheterization, when they catheterize the heart, they're usually placing the pulmonary artery catheter. So again, they'll usually go in through a vein in the neck or the groin or an artery, and then they'll thread it through so they get to the heart. And then that way they can check pressures of the heart to have more specifics about if the patient needs open heart surgery, if they need to have valves replaced, if they have left-sided or right-sided heart failure, that sort of thing. Okay. Hyperlucency.
I had a question. I know we're going over these ones, but the 33 and on wasn't on our list.
Oh, I'm sorry. I must not have copied the back. Okay, well, write them down so you have them.
If I just was like, did I miss? I thought I missed something, but I kept looking.
Yeah, I must not have copied the back side of it. I'm sorry.
No, you're fine. I was like, what is happening?
Well, y'all got off easy. only 32 instead of 36. But no, we'll just go over these briefly. So hyperlucency, you'll see that term. And of course, like we said, lucent or lucency on a chest x-ray indicates dark or black on a chest x-ray. So if it's hyperlucent, then it's overly dark, and it usually means that the chest film has been overexposed or over-penetrated, okay? So hyperlucency indicates that it's overexposed or over-penetrated, and it appears too dark, okay? So you saw that even on our normal chest x-rays, it should not be pitch black in the lung field, right? It's more like a dark gray. So, but if it's completely black, then that is indicative of hyperlucency, and it's not a good chest film. If it's hyperlucent, a lot of times you miss vasculature. You should be able to see some vessels on the chest x-ray, but if it's over penetrated, then you won't see the vasculature that you should be able to see on that chest film. So then it becomes, it's not a good film. They probably need to redo it. Okay, hydropneumothorax, from the name, I'm sure that you've guessed that it means both air or gas and fluid in the pleural cavity. So we've heard of a hemopneumothorax. This is a hydropneumothorax. So it could be a hemopneumothorax. We just don't know yet because we haven't done the pleural effusion yet. So it just indicates that there's both gas or air and some type of fluid in the pleural space. So you can see this pretty easily on an upright chest x-ray. You'll see that there is fluid here, and then you have the deep sulcus line here. Okay, so this will be air, and then this will be fluid. Okay. Any questions? Any questions? Okay. Couple other, go ahead. I'm gonna pull up another, just so y'all can see just a couple other images. But you
So,
can.
so last night when I sent you my homework,
Mhm.
I was talking about like in Butler figure 29.19. It at first I thought possibly like a pleural effusion, but now that we're talking and going over this, I think it might be that one we were just talking about where it was too black, like it's the hyperlucency. Because you don't see any signs that it would be a pleural effusion, but yet it's still really dark in the lung spaces.
Yeah, I can't
barely see the ribs.
Top of my head, but I did. Oh, I don't think you were on then, but those images on Butler are awful. I think it's because of the type of paper that it's printed on. So don't like rack your brain trying to figure those out. Egan has better pictures, Clark has decent pictures, and even rely on like online because on your phone it's easier to see. So with Butler, you know,
You are now muted.
I'm glad you answered them, but those are terrible images in Butler. One of them is supposed to indicate, I can't remember which number it is, but all it says is that there's a trach tube in place. And the rest of the chest x-ray looks terrible. Did y'all find a trach tube on any of it, by the way?
No.
So that just speaks to the quality of it. So like, I hope that you didn't let those stress you out too much, because I mentioned it was some of us that were going over other stuff yesterday, that the quality of them are terrible.
Okay.
Yeah, so don't stress out. We can go over them though, just so you can have an idea of what they were trying to get you to see. But on half of them, I can't even see what they were trying to get you to see, because it's just not very good quality at all.
Okay.
We have some websites. So the video that I sent, and I'll send you guys some websites as well. They're not part of your clinical simulation, but it's just so that you can expose yourself to more x-rays, because obviously x-rays, like anything else, are going to look slightly different from person to person. So every single pleural effusion will not look exactly the same. Like we saw some that the meniscus sign was super evident, and others it's not. So there's going to be slight variations, but I'll send you guys some websites just for more exposure. They have like case studies and where you can pick what you think is the problem and things like that. Okay. So, but these are just some more images that I wanted you to see to kind of cement what we just talked about. So of course, this would be a normal chest x-ray. And so this is what I mean by, if it's not hyperlucent, you can see vasculature. So these are not infiltrates. This is just regular veins and arteries that you should be able to see on a chest x-ray. Also note the heart size. How big should the heart show up on a chest x-ray? How big should the heart be? How much of the diameter of the, or the width, I should say, of the chest cavity should the heart take up? Anybody?
You are now unmuted.
I'll let you guys find it in your reading, and you can tell me Monday. But that would be how we can tell that the heart is enlarged, because it would take up too much of the diameter. There's a specific measurement that tells us about how much of the width, I should say, the width of the chest that the heart should take up. If it's bigger than that, more than that, then it indicates cardiomegaly. So this would be a picture of a tension pneumothorax. So if you, I don't know how well you guys can see this, but you can see the outline of the lung. You guys see that?
Yes.
So the outline all the way there. So all this space, and notice, look at how hyperlucent this is. Look at how dark this region is. that is not normal. So this is what normal air-filled lung should look like, and versus this is much darker. And then you can see the outline of that lung there, that the lung that is collapsed. Okay. You can also see the shift in the trachea. You see the tracheal shift. Everything is kind of shifted in the other direction. See how everything is kind of being pushed towards this side?
Yes.
And I can't see you guys because I have this pulled up over you so I can scroll. So verbal confirmations, please, thank you. So you can see how everything is kind of shifted to the opposite side, hence a tracheal shift with a tension in pneumothorax.
I can actually, like, now that you're like pointing at it, before it's just like kind of hazy. Yeah, you see the lung, but then if you really look through that, you can see the rest of the trachea, like literally pushed all the way over.
Exactly, you can. Yep. So, and that's why, again, with chest X-ray, I want you guys to, again, read your chapters, read over your PowerPoint, highlight stuff in your PowerPoint. But for me, it's the images that cement everything. You can tell me about what I'm supposed to see on a chest X-ray all day, but if you don't show it to me, it doesn't make sense to me. So this is why we're spending time going over the images. You guys can read it on your own, but I want to make sure that I show you and point things out to you. Okay?
Is it 50% for the heart?
It is.
Okay. I didn't want to be wrong, but I thought that was it.
Yep. Yep. So usually the heart takes up about a third. Let's go back to the normal one. Usually the heart takes up about a third. And in my mind, I just kind of split the chest into 3, right? So usually the heart takes up about a third of the width of the lung field, of the chest field, the thorax. If it takes up any more than half or 50%, then usually we consider that cardiomegaly. Now, keep in mind, well, what type of X-ray might you see kind of a false alarm as far as cardiomegaly on? Where might you see like a false image of an enlarged heart? What kind of X-ray?
Would that one be when you're doing the lateral?
No, on the lateral, you just really remember we didn't really even look at the heart.
Would be the anterior posterior?
The AP, because that's where you start to have distortion of the heart side. You start to see heart shadows, things like that. Remember, your better quality is going to be your PA X-ray. So yes, sometimes you have a misdiagnosis of cardiomegaly on an AP chest X-ray simply because the image is distorted.
Okay, so if they're diagnosed with the cardiomegaly, would they, do another one and do a
Yeah, they would do follow-up for sure. Mm-hmm. Yeah, and I'm sorry, I shouldn't say it. It's not like they do one chest X-ray and they're like, oh my gosh, your heart is huge, and like now you are stuck with that stigma of cardiomegaly. They would assume it, maybe put it as a differential diagnosis, but then investigate more. Okay. So this is another image of a pneumothorax. You see that deep sulci line or sulci line. And so this is the outline of that collapsed lung. You guys see how little and shriveled it has become?
Yeah.
Yes. Yep. And then you see how much darker and clearer that is. No vasculature, right? None of that you see over to this side. Much darker. That indicates there's air in the pleural space.
Because you're not, like you just said, you're not seeing the lines like you are on the left side.
Exactly. And the color is much different as well. So much darker here. Look, right here, you can't even see the rib anymore because it's so dark. See that?
Yeah. Oh, right there on this bottom one right there.
Yeah, right here. You see the rib, the outline of the rib is completely go away because it's so dark. Okay, so this would be another example of a whiteout. It could be atelectasis. This could be Mallory's favorite, an RS patient. And of course, that would be caused by fluid in the lung. A massive amount of fluid in the lung could be because of pneumonia consolidation. So it's just white, just a whiteout. And we'd have to figure out why, especially at the bottom. Look at how bad that is. You can't even see structures anymore. Can't even differentiate where the diaphragm ends and where the lung field begins. This becomes a blur. So then depending on how else the patient presents, you figure out what to do. Another whiteout, this is a unilateral whiteout. Okay. So at least they got one lung that's still semi-okay, but look down here, still not completely clear. Have some of that not consolidation, opacities there even. Okay, another picture of the honeycombing. Okay, and again, that indicates fibrosis. So that honeycomb appearance on a chest x-ray shows up on a chest x-ray, then you could do more detailed imaging like a CT or MRI. Okay, this is what it will look like on a CT scan. So you see all the little individual circles, and it looks like a honeycomb.
That looks worse.
Yeah, because it's more detailed.
Yeah.
So that's what you get when you get the more expensive, more detailed imaging. So, and again, a lot of these are just bigger pictures from before so that you can see them a little better, hopefully. Yeah. So the different types of opacity. So the reticular, see, it's more liney versus this one that looks like dots. Looks like somebody just took a marker and put a bunch of dots on this x-ray. So, and then you have that ground glass appearance. So again, that's usually because of an inflammatory process or interstitial lung disease, and it looks like somebody just broke a mirror very, very badly, or glass, shattered it. So this would be that thumb sign on a lateral neck x-ray of someone who has epiglottitis. You guys see the thumb sticking in the airway there? Mm-hmm. So obviously, and look at how narrow this airway becomes. You guys see that? That will be why your patient needs to be intubated right away. This should be the diameter of the trachea. And they're down to that. Okay, so that's why epiglottitis is an emergency. That's why these patients need to be intubated quickly. This would be an example of what?
Croup.
Yep, croup, because you see that steeple sign. You guys see that?
Yes.
Yes, ma'am.
So that's what we mean by the steeple sign on a lateral neck x-ray. Okay, so a lot of times the chest x-ray on a croup epiglottitis patient won't show you anything significant in most cases. You have to x-ray the neck. Okay. So these are some examples of air bronchograms. So again, remember with the air bronchograms, what you're basically saying is an outline of the airway. So the airway or the bronchioles, bronchi are still filled with air, but the outside of the lung tissue is filled with consolidation or anything other than air. So as a result, you get the outline of the airway. Can you guys see that okay?
Yes.
So that's your air bronchograms. Curly B lines, again, those little straight lines that show up in the lung bases. What are they indicative of?
Edema?
Pulmonary edema.
Yeah, I don't like to say it before.
It's okay.
That was stuck in my head.
And then everybody's favorite, pulmonary edema. So, and again, that bat wing appearance. So you're going to see, again, those fluffy or hazy infiltrates, opacities, but they're going to be bilaterally and they're going to be up here near the highlight. Pleural effusion, of course, we see that blunted costophrenic angle. You don't see that sharp angle like you see here on this side. Okay, this is your costophrenic angle. It should be sharp because it should be the diaphragm and the lung coming together. Here, it's not sharp anymore. Okay, and you start to see the meniscus sign. So those are the telltale signs of a pleural effusion. Okay, again, another example of a meniscus sign there with pleural effusion. Okay, and again, that costophrenic angle is not sharp. Okay, and then again, a lateral decubitus x-ray, that fluid goes to the side as the fluid moves with your patient, basically. Okay, again, it is not in the lung with pleural effusion. It is in the pleural spaces outside the lung. Okay, plate-like atelectasis, again, still the same old atelectasis. It's just that you'll start to see flat lines appear on the chest x-ray. Okay, cardiac tamponade, which is you'll see the water bottle sign on a chest x-ray as a result of cardiac tamponade. And it looks like an onion to me, like that's how I remember that one. So it's more rounded. You don't see that the heart is going, more towards the left. It's more rounded, more bulbous. It looks like a water balloon, really, to me, more than a water bottle. Okay, but that's an indication, again, of cardiac tamponade. Okay, tube placement. That's one of the major reasons, at least one of the major reasons that they do chest x-rays. A lot of times you have a code, you intubate the patient, x-ray is standing outside the door waiting for you to move out of their way so that they can come in and do a chest x-ray to confirm that the ET tube is in fact in the right place. Okay, so the ET tube you'll be able to see in the trachea. You'll usually be able to count the vertebrae to see exactly where it is. It should be a few centimeters or inches, depending on which unit of measurement you're using, above the carina. Your ET tube should not sit right at the carina. It can make your patient cough and cause irritation to the carina. So usually about 2 to 5 centimeters above the carina is where you want your ET tube to lie. And that's at about the 3rd or 4th thoracic vertebrae. So in the video, we'll point out some ways that you can identify the carina, the trachea, and also the ET tube as well. Okay, so this is just kind of a side-by-side comparison of a PA, posterior anterior chest x-ray, versus an AP, and you can see that the quality is a whole lot. This is the same patient done back to back. So you can see that the quality is much different. The heart looks much smaller. Look at the distance you have here between the side, the thoracic cage and the heart versus what you have here. So less shadowy. You can see the ribs more clearly. You can see the air-filled lung more clearly. Okay, same thing here. This is a PA versus an AP. So you can see that there's a drastic difference. I think this one might be a little bit over penetrated, though it looks kind of dark, but just a drastic difference. And even the size of the heart, especially, even the size of the lung fields. Okay, and just another example of tremendously smaller lung fields here as opposed with the PA x-ray. Okay, and just some ways to identify PA versus AP. They should all be labeled. It will usually have a little indicator there, but if it's not, these are some ways to identify which one you're looking at. Okay, another view that is not as popular, but sometimes you'll see it. You'll also come across it in your reading. It's called the lordotic view. If you remember back from not A&P, but Unit 1 last term, if a patient had lordosis, that was kind of the sway back. So look at how this patient is positioned with the sway back position. And so they'll have that view done as well to look at specific structures or to confirm specific conditions. Apical view is where they want to really focus on the apex of the lungs, the tops of the lungs. And that's it. Any questions?
No, I think that really helped to see, like you were saying, one thing is to read it and to kind of know, but then to see it, you can kind of put those pictures together, and then just going over what disease matches with what and why and how and all that.
Yeah, that's what I think helps best. If you find that something else helps you more, let me know and we can go over that too. But like I said, this will be pretty much our lesson on chest x-ray, unless we need to go back to it next week. But just make sure that you do your reading, make sure that you've taken notes and that you noted anything else that you need to go back and look at. But for me, when it comes to chest imaging, I need to see it and then I can associate it. So like I said, I'll send you guys some you have the video that's part of your clinical simulation. I know that it's Friday. So being that it's Friday, I will give you until Monday morning at 8 a.m. to watch the video, do your step-by-step to do your clinical simulation. Because obviously I can't do chest x-rays on y'all in the lab. So we won't have a true chest x-ray lab. It'll just be more discussion and visual, okay? So you have that video that I sent you, that's your clinical simulation for chest x-rays, okay? But you have until Monday morning to turn that in, okay? I'm also gonna send you guys some websites. You don't have to do anything with them, but I'm gonna use the honor system. I do want you to spend just even a little bit of time just looking at them. It'll give you more practice. It's something that you can go back to and use in the future as well for when you need to go back and review your chest x-ray information. Okay, any questions?
So that clinical stimulation is not to be done on next week, Wednesday. It's to be done today through Monday and do Monday morning at 8, correct?
Right, just this time. Usually our clinical simulation will be reserved to Wednesday, but because today's the only day we'll be focusing on chest x-ray, it's the one off one. Yeah, but you do have until Monday to turn it in.
Okay.
Okay.
So when you say clinical simulation, like in other words, if we were at the lab, we would be getting, like you have x-rays that we would be able to look at?
Really, the best way to teach to teach x-rays, because like I said, we don't have an x-ray machine. Even if we did, I couldn't do x-rays. We couldn't do x-rays on each other. So lab x-ray interpretation is never a hands-on lab. It's just really, we look at images together and you figure out what's going on. And the best way to do that, the best quality ones, really is now what I can find online. We have an x-ray, we have some x-rays, and we have you remember if you watch the old movies, you see that they put them up on the lighted background. They don't even do that anymore.
Yeah, everything is all computerized.
It's digital, exactly. So we can do that in the lab, but it really doesn't help you out more because that's not how you will see x-rays in real life anymore. So that's why it's really not a hands-on lab, even if we were in the lab.
Okay, so in other words, we're going to be doing what we did before with the step-by-step on the other videos. You want that done for the chest x-rays,
Yes.
for the what you sent us, the video that you sent us?
Yes.
Yeah.
Mm-hmm. Did anybody not get the video? And it has little instructions on it too. Okay, so please make sure that you got that. But yes, it is not due today. It's not due until Monday. So you can just write it out just like you did the other, like what I'm going to say for that clinical simulation.
And basically, since I'm sorry, you probably said it. The lady from the school and financial aid trying to call me like 3 times, but
You are now muted.
so we just basically write in the description and how we know each x-ray is what, since there's no step-by-step.
Well, see, like I said, I put instructions on the video. There is,
okay.
It's a video on how to, like a systematic approach on how to interpret x-rays.
Okay.
Yeah. So use your video and then use, I think it's Egan that literally has a step-by-step approach to like what to look at first, then what to look at. So I want you to write down your step-by-step approach and then also how to identify organs like the heart and like the diaphragm, like we talked about, how to identify other structures, what's the significance of, like if you see a tracheal shift, what does that signify? If you see a blunted claustrophrenic angle, what does that indicate? So that sort of thing. So you're going to be using the video and your material. And yes, you can go through and, okay, if you see this, it means this. If you see this, it means that. If your diaphragms are flattened, it means this. And then the video will give you the step-by-step.
Okay.